Hi everyone, welcome to the DHSS webinar on the rate methodology update. We're just going to go ahead and let folks continue to gather and we'll get started momentarily. Looks like the participants have stopped. I will just say that I'm going to walk through, sorry, Molly McGarrick, Secretary, have other members of the DHSS team on, and then Mark Podrasik, who has been our subject matter expert and consultant doing the bulk of this work in partnership with all of the DHSS divisions, also having conversations with stakeholders. And so we have submitted the final epilogue compliance report on the roadmap. That's what we're going to be walking through today so that you all can see exactly what we submitted. For those that have participated in previous webinars and conversations that were at the end of January, you will not see really a lot of difference in that because the feedback that we received did not recommend any substantive changes. There were some questions. Obviously, the ongoing question is, well, does this generate new funding? I'm sad to say this afternoon, the answer continues to be no. Those are separate processes, but we do continue to move forward, again, in the interest of transparency and accountability and being able to get to a place where irrespective of what service we're talking about, if someone says, hey, I have an extra $1 for you, DHSS would be able to say, again, in a transparent, predictable fashion, this is how we would spend that $1. I will walk through a portion, again, walk through the memo that we submitted, again, just so you see exactly what we sent. I will turn it over to Mark to walk through in more detail some examples, and then we will open it up to questions. Please use either the chat feature or the Q&A to submit your questions. We will try to screen as we go through. Kiki will be doing that, but we will take time to pause, and obviously when we're done with our portion of the presentations, we can just focus on the questions. So with that, I'm going to attempt to share my screen, which sadly is still a thing that I get excited about doing correctly this far into the pandemic. I think I did it. Awesome. So again, this is the memo that we submitted. So again, for those paying very close attention, it was section 42 of the fiscal year 2021 grant and aid budget was this epilogue for this next round of work. And it again was to address the recommendations that were in the epilogue, the previous epilogue report we had submitted. Two people are. Again, the background, we had the 2020 study. There were 9 recommendations. The first 6 were applicable to all the methodologies, and the last 3 were applicable to the categories of service. And you'll see as we walk through this memo, we'll show the recommendations once again for those that haven't watched this as closely. But really you'll see, and we call out in this memo, and again, for those who have participated on previous webinars and conversations, this roadmap is really the key recommendation because it's how we get from where we are today to, again, those transparent, predictable methodologies, as well as a cadence for updating those methodologies. So again, people understand that, you know, if you're in year 1, we look at it again in year 5, as opposed to now where people, you know, absent the IDD and then the childcare, it's not always predictable what the methodology is and when we're gonna look at it again. So again, to specifically walk through recommendation number 2, so we needed to create a roadmap for how we get from where we are today to where everyone agrees we need to go. We need to look at whether Medicare has a methodology. Is there an opportunity to incorporate a value-based component, again, to get us away from fee-for-service? We need to call out and acknowledge, does DHSS or anyone need additional resources to create the methodology? How do we identify where those resources would come from? Again, current resources and gaps. Really critical and very important, especially as we're talking about rates paid to contracted provider partners. how are we communicating, how are we taking into account feedback and perspective, as well as looking at things like claims, so both qualitative and quantitative data, and then talking about timing and cadence of updates, obviously with an eye to the annual legislative budget cycle, and then really the timing that we need to introduce value-based initiatives in rate methodology. Some of our services are much farther along in a move to value than other services. So again, how do we call that out and how do we talk about that? So again, you'll see here, which is in our memo, that really recommendation 2 is the crux of the recommendations, and the rest of them really complement our recommendation 2. So this just walks through what we included in our memo. So we gave the 12 key activities, a roadmap for rate development, key questions, and then the status of work towards the recommendations. So again, just kind of walking through what we submitted so folks can see. We put out questionnaires, looking at rebases. This was really the heart of the presentation that we did, again, in January and February. And so we talked about, there's different approaches, but, we need to look at what surrounding states are doing. And we will put this in the chat box, but the tools and the resources for those that were not with us and want to see this whole journey, including what we submitted to CGO, you can go to this website and see all of the materials. So sorry, I'm gonna make you a little seasick with the quick scrolling. So again, these were the 9 recommendations that were in the FY20 Epilogue report. So build specific rate methodologies, not really a one size fits all, but look at services, including intensity of services. This number 2, the long-term roadmap, look at recommendations that augment existing staff, a more formalized public notice and public engagement process. Again, when rate methodologies are undertaken, how do we build project-specific work plans? So I'm going to scroll through this quickly because we're going to revisit this again a couple pages down when we say what the progress is. So scrolling. And really, this is another key feature of the conversation in January and February. And we had put it out there as here's an example of a roadmap in terms of when we would look at revisiting certain rates and for either Rebase or or update. And we did not get any feedback. I mean, obviously everyone would love to be in year 1, but we did not get any substantive feedback that said, this cycle is inappropriate or, do this instead. And so this is the recommendation that DHSS has around, what is realistic for the resources that would be needed, what would be realistic in terms of timing. Again, as much as we wish, it is impossible to do all of these in a single year. And so this is the proposed roadmap. Sorry, I'm going to try to zoom out a little bit so we can watch this all on one page. Yep. So Mark will talk a little bit about this more, but again, this is, let me try to, hit the sweet spot of like not super zoomed, but zoomed a little bit more that folks can see. So cycle 1, we would look at, dental, lab, radiology, hospice, dialysis, home health, nursing facilities, assisted living, and then the rebase, which is, the really intensive work because the methodology doesn't really exist right now, would be around the substance use disorder services. Many of you know we actually have a grant from the federal government, CMS. That work is already underway. We look at federally qualified health centers, and then obviously we just released the childcare rate study, which is actually required by Administration for Children and Families under federal HHS every 3 years. So again, this is really reflective of work that either is already in progress, has just been completed, or again is realistic for cycle 1, and then cycle 2, cycle 3, cycle 4. So again, absent specific feedback from JFC saying, no, don't do this. This is how we will proceed. Once we identify funding to continue on this journey, unfortunately, it is not free, but we agree this is the next step forward. And then again, to revisit the 9 recommendations. So we completed recommendation 1, which is the roadmap. Some of these services, again, the inpatient services, we have slated for cycle 4. So this is a walkthrough of where we believe each of the recommendations are based on the work that Mark has done on the roadmap. Make sure I don't miss anything else. And again, you'll see that, you know, some of these, again, they refer back, but in this comprehensive roadmap, we believe we have captured and really encapsulated a lot of these, a lot of the recommendations, and have a strong path for moving forward. And with that, since I think, Mark, you have the more interesting part of the agenda, I want to turn it over to you to talk through some of the more details that I know people will say, well, what does it mean? What do you mean questions? What do you mean survey?
Thank you, Secretary. Hello, everyone. Mark Podrosic from Health Management Associates. And I'm going to share my screen as well. In the absence of time, as the Secretary said, we did not really change the presentation that was shared with those of you that attended back in January. Can you see my screen now? Okay. But I just wanted to remind folks, or those that may not have been on that call, we had proposed for, and I'm going to go back to the roadmap page that showed the green box and the blue box. The green box, those services were things that primarily delivered by the Medicaid agency, DMMA. They key off of a Medicare methodology. It's either pay the full Medicare rate or say 95 or 98% of that rate. There's not as an involved process to do a rate update for those. And they're in fact pretty much done on an annual basis already. So that would continue. The blue box represents those services that would be more involved. So for the most important piece is to understand provider costs and utilization of the services. Secondarily, in many situations, it might be that the department wants to entertain a different way on how the services are paid going forward. So we call those services the rate rebase projects as opposed to the rate update projects. Here on the rate rebase projects, we came up with 12 steps that we believe are common to all of them. The PowerPoint presentation on the website goes through each step individually, but I just wanted to show you this schematic briefly. Sometimes that informs the level of intensity, and there needs to be modifiers to certain rates. Meet with the stakeholders early on in the process to orient them about how the process is going to go. How long do we think it's going to take? Where will we need them to be involved? Collect cost and other related information from the providers that are paid under these rates, as well as information from other sources in addition to the providers, because it might be that there might be a need for other external sources as well. And then compare and contrast the data. What I mean by that is the most typical scenario is that oftentimes if a rate has been on the low end of the scale, and as a result of that lower rate, rates paid for hourly wages to staff are depressed from what optimal might be, it's circular, right? So if we collect provider costs, they're going to show lower hourly wages. But if we compare that to an external source like the Bureau of Labor Statistics median or 75th percentile, that might be a different value. So we don't want it to be a self-fulfilling prophecy that the costs always drive the rate. Each of those things are key informants to developing the rate. So step 6 is to build draft rates. And then step 7 is to use recent utilization from the state to model what the rate payments are under the current rate structure versus what they might be under the new proposed rate structure. Share those results with stakeholders, make adjustments as necessary. This is often an iterative process that can take multiple weeks. It's not all done in one meeting. Certainly identify and plan for system updates, which actually often happens even up here in step 1 and 2, but certainly by step 9. Do a public comment process, finalize the rates and the fiscal model, and importantly, secure federal approval to get the federal match rate where that's necessary. This, and I'm going to go through a whirlwind here and skip to, I think it's, yes, slide 30. So this is the roadmap again. And when I was referring to those steps, I was referring to these services down here. We came up with 20 different categories that would fall under the more involved rate rebase project. So next, what I'd like to show you is another document that's out on the web page. I'm going to show you the first couple of pages here. To assist the department with these 20 categories, which is what appears down the left-hand column, we went out and inventoried available information to get the ball rolling in preparation for whenever it's that service category's turn for rate rebase. The numbers, rows and columns represent the number of states out of the 5 neighboring states for which we were able to obtain information. So we asked ourselves to look for, is there a fee schedule available and can it be downloaded, which are actually 2 different things because sometimes you can't download them. Is the methodology on how the state pays for the service available, and is that downloadable? And if in the cases where it was, we downloaded it and provided the information to the department. Then we looked and kind of reviewed that methodology and found, are there different ways that the services in the category are paid for? So as an illustration, I'll walk you through the behavioral health service category, where we found 5 fee schedules, 4 we downloaded, and 3 methodologies. And amongst those, we found some are per service, like a fee for service, whether it be a psychotherapy visit or a one-time assessment. We found per diems, of course, if it's like a residential program, which would be typical to pay on a per diem basis. And one state even had something that was kind of an ad hoc methodology. The type of rate obviously will vary by the service categories. You can see here, nothing was completely surprising to us and as we reviewed it, but it's just a good piece of information for the state of Delaware to have to arm themselves when it's time for them to contemplate how they might update their own rates. The second page of this 2-page summary gets even more detail. What data sources did the said state use to update their rates? Was there an acuity adjustment, meaning the level of need of the clients? Is there a different rate for high intensity versus lower intensity? Is there a notification of when the rate updates would occur? Is it evident in the documentation? Here's how many states reported that. And this green section is really more Medicaid speak for the state staff, particularly in Medicaid, on which authority was the approval granted to that state to ensure the federal match dollars. So this document is 15 pages. This is the first 2 pages. And then the remaining pages all look like this one. They're 1 page, but they're organized in the same way. And so again, behavioral health is the starting point. And you can see the topics of the column headings are the same as what I just mentioned. So here, instead of saying the number of states, we provide the details for behavioral health services specifically of the neighboring states or nearby states, where we got data and where we did not, the methodology, the authorities, the rate types they use, the data sources, and the acuity adjustment, and if they publish rate updates or not, and then the links to that, to each state's information. So there's one for each of those categories that is in the blue boxes. Another piece that we provided to the department is in the PowerPoint, we posed towards the end of the slide deck 7 key questions to ask as you're about to undertake a rate rebase project. So here, these are 2 pages long each, and behavioral health happens to be first again in the document. So the way this is organized, I'm going to quickly go through just to show you the 2 pages and then go through each section. The green is the question that we're asking. So what divisions pay for behavioral health services in the department? What information is available from other states? What data sources can be or should be used? And then the next page is the department contemplating doing the same methodology, that is just updating the method but using new cost data? Or is it not only using new cost data, but also thinking about a different way to pay for the service as well? How long do we think the project's going to take? Are systems changes needed? And what resources are needed? So each of these really relates back to the section in the first document that the secretary showed through about the elements of the roadmap, if you will. So back on this first page, there's a legend that shows which division we're talking about here in this section. And so whether it's DMMA, which is Medicaid, or DSAM, which is mental health, when was the last rate update? Is there a policy manual published? When was that updated? Is there a billing manual published? Is that updated? Sometimes we have some notes out here. So this is my team's review of the data, feeding it back to the department. So when it's time for that rate rebase activity to occur, there's at least something to get the ball rolling. Clearly, there would need to be a re-review of this because this is all as of the end of March and things could change, but it's at least a one-time source to go to information. Section 2 was I was showed you from the other document, the details on the neighboring states and the references. It's just summarized here on this page as well. And then the data sources. So for example, down here it says for behavioral health provider costs were looked at. And 2 states did that, New Jersey and New York. So of course, our recommendation would be, well, Delaware may want to call their peers in New Jersey and New York and get their provider surveys and see what they asked for, and maybe ask somebody that worked on that project, how did it go? Did they want to ask for other information they should have, etc. And then this last page that I'm going to review before questions is questions to pose about the rate rebase methodology. Is there an adjustment for acuity today? Should we consider one in the future? Should there be an adjustment for group size in the behavioral health setting? A one-to-one psychotherapy visit would be a different rate than a single practitioner to a group psychotherapy, for example. Does it need to be consideration for locality? Urban versus rural, or hard to reach areas of the state might have a different rate. Should there be a quality-based incentive entertained? It might not happen immediately, but get the building blocks going to build that infrastructure for an ongoing piece, as well as payment for outcomes. In the PowerPoint, there's a one-page slide that shows for all the blue box services, the 20 services, an estimated time frame. It is one of these 4 ranges. We pin this one at a 12 to 18 month life cycle to go over those 12 steps I showed you before. System changes. It looks at not only does there need to be some, but also an assessment of how complicated they are, because that can drive the implementation and the timing. So our experience has found that systems changes often the things that hold up processes. So getting that known earlier is better. And so we just wanted to provide the department with our assessment from our working in other states, what we have found and what it might take, and to make sure that that does not get lost along the way. And then the resources from various stakeholders, not the least of which is the systems people, which is Gainwell in the Medicaid space, providers, MCOs, CMS, other divisions, etc. So there's this 2-pager is for each of those key services. So you can see we have this along with the research of the other states as well. So at this point, that's what I wanted to cover. And I think we're at the halfway point, which is what we were hoping for, so that we can open it up to questions and certainly go back to anything in particular that needs to be readdressed or confirmed. But at this point, I think, Kiki, we're ready to open up for questions.
I just want to say before we do that, obviously huge thank you to everyone who's participated up to this point, stakeholders. I also want to acknowledge all the DHSS staff that participated and provided Mark with all the information he needed. And then I think we're incredibly fortunate to have Mark Podrasic's expertise. He has not only done a lot of work in Delaware to get us to this point, but he's done this work with states across the country. And so I know this process hasn't moved as fast as people would like it to, but I think having Mark and his expertise and being able to pull from work he's done in other states allowed us to keep moving through this, even though the pandemic was obviously pulling DHSS resources in other directions. So Mark, I just want to acknowledge you and thank you for all of your help to get us to this point.
So the only questions I see so far are, can we get the link to these PowerPoints and presentations? And yes, all of these are already posted online at the link that Michelle put in the chat if you'd like to review them at your own leisure. One other question is, how long do you expect each cycle to last?
So I think we looked at these in terms of, it's going to vary by service. And Mark and Michelle, please feel free to jump in. I mean, we would kick off a process and acknowledge that, we're going to try to do it within budget cycles. But as you saw in the previous slide, I mean, some of these rebases are going to span multiple fiscal years because it's not a 6-month process. A rebase can take longer. So maybe we can start it in the first fiscal year, but it will potentially straddle, maybe we don't get the rates until January. When we kicked it off in July, we don't get it until then past that next July and finish it in January. So it really is dependent on the service category. But Mark or Michelle, I don't know if you have anything else to add.
Yeah, I can add, we were hesitant to call it year 1, year 2, because some services could be rebased and done in 6 months, whereas others clearly could be a 12 to 18-month proposition. So it's more just kind of a way to illustrate a batch of services that will all happen around the same time, some with longer periods and some with shorter periods, none of which may be exactly 1 year. They could be less than and greater than. So that's why we use the term cycle. So it's almost thinking of it as pushing out a certain group a similar period of time versus the next group versus the next group.
And I think the hope too is, this is how we do some of the rates now. Like again, childcare is on a 3-year cycle, that as we move this forward and we get better at this, that we would be able to be more explicit, cycle 1, these services kick off and then we will revisit, home health at year 3, or, this is a cycle. So we will get better at saying, again, how long it takes, and hopefully too, as these become more routine processes, that providers are used to, that we're all used to, that again, we get to that very clear, this is what the cycle means. But I think the other piece that I want to acknowledge again is that many of these involve all of the same staff. And so that's why, we really need to look at them in buckets or cycles, because, Medicaid is involved in every cycle. So to do all of these at once, essentially the Medicaid team would do nothing else but do this work. And obviously there's all of the regular work they do. So we were trying to, again, create a more predictable cadence, but also be honest about the amount of work it takes and the fact that we can't do all of these services at the same time. We need to have some break or some cadence where we finish one and then start another.
There's another question in the chat. Where does PPEC services fall?
I apologize for my ignorance. I'm not familiar with the acronym. What are we?
I believe it's the prescribed pediatric extended care centers.
Yeah, I don't know, Michelle or Mark, if you know where they would.
Mark, and I want to double check on this one, but I feel like they were probably within like the skilled nursing facilities, but it's not the same as a traditional skilled nursing facility. So I would want to check, and we could get back to them.
Yeah, no, that's a very good question. And part of it was part of the rationale for the development of the cycles themselves and the categories of service is that I totally can reflect about that this provider category is unique to, say, versus skilled nursing or assisted living and things like that. So they're not one and the same, but the process and the type of rate development is similar. So it would make sense that looking at skilled treatment like those services would all be happening around the same time. So I'll defer to the department on where you might want to call them out, but it would seem that in other words, one of the visions would be that as we go through some of the cycles, whoever's doing the work, it might be that the leadership of the division that is responsible for the services would meet with whoever's doing the work, but then there might be some meetings that are common to multiple provider types that will all fall into that same cycle because they have similar requests of them through a survey. But then there might be a need to meet separately with each of those provider groups about the nuances that are specific to their services, because no one provider survey can cover all these service categories. So there needs to be a recognition that there's those nuances. So oftentimes that's what we find is that, let's say hospitals are an example, where acute care hospitals and IMDs and freestanding psychiatric facilities, and they're all hospitals, but they have very unique things about them that need to be addressed in a survey process. So that could be, we could fit this provider group into wherever we believe is most appropriate from a similarity of process standpoint, and then have a separate meeting when appropriate for them on their particular services.
The next question is, if and when a service is up for an update or rebase, what will the formal structure be in terms of DHSS reaching out to providers or their associations for their input?
I think this is what Mark was pointing out, where we have these established questions where we say, this is what we're looking for, this is what we would need, this is how the process is going to move forward. We estimate it's going to take 12 months. This is the point where, we have claims data, but we really need another piece of data, or we need cost data. This is what other states are going to do. So it really, again, depends on the specific service that we're talking about. Michelle or Mark, I don't know if you want to add anything else, or anyone else, feel free to, DHSS, feel free to jump in.
Michelle, anything?
I think that what we'd also want to point out is that this is something that is done where we do have existing methodologies that have been rebased and reviewed throughout the years, and that, as the department engages in that rebasing and reviewing, the provider community is informed at the outset, and we have that precedent from some of our other rate reviews and rebases, specifically like childcare and the direct service providers. That provider engagement is a critical and key piece of it, and that's why having that cadence is so important, and having it so that the provider community is aware as well.
As I was suggesting the 12 steps, my personal view is that the providers should be part of the process in every service that's updated. But as Michelle said, that can vary based upon what is actually occurring. So in the roadmap, in the green box, which is just the rate updates, there should certainly be a public notice that rates are being changed. And if there's something of significance that needs to be alerted to, that's all part of that process. Oftentimes, there's a meeting with the relevant association, whether it be the medical society for the physician rates or what have you. They get a public process and a feedback loop, but that's different than the blue group, which is the full rate rebase, which is not necessarily just a one-time thing. It's a continuum across the whole project. So to me, the key points for provider interaction would be at the very beginning, here's the work plan we've developed, here's how long we believe it's going to take, yes, we are entertaining new methods of payment, or no, we are not, we're just updating costs. What do you think about that? Then the next piece might be, if we need to relook at service definitions, here's what we're thinking of changing them and the implications to the rate or rates to do that. Then there'll be a longer phase, that's the provider cost collection, a webinar to introduce the survey instrument, ongoing, telephonic support if needed, feedback to the providers. Here's what we got back from the surveys that were submitted back. And then here's how we're going to use that data to inform our rate development. And then introducing draft rates. And then typically, like I said, it's an iterative process to fine tune the rates. And then ultimately the final public notice about this whole process. What are the final rates? What is the fiscal impact? When is it going in? Anything else that's relevant to the topic. And then the documentation is like if a provider manual needs to be updated or a billing guidance needs to be updated, those are also part of that. So there's at least 5 or 6 touch points in the blue box services along the way. And oftentimes that's quite frankly why the projects take longer, because it is incumbent upon the state to get the feedback, but it takes a little bit longer to do that.
Just to follow up from the person asking the question, saying that they believe their point was that there is important that there be an established mode of communication, point of contact, set of expectations, the actual technical aspects of providing feedback and keeping entities informed.
We totally agree.
And my experience has been that states often use, if there's an established association, as a primary point of contact. But there have been numerous projects I've worked on with states where also there, for good reason, needs to be sometimes some one-on-one meetings with individual providers because they do a specialized service in that category, or whatever. Maybe they're doing something new that the state wants to expand. So sometimes there needs to also be exogenous meetings outside of the association formal process as well.
The next few questions are about how we've determined which updates and rebases are part of which cycle. How did we do that? And there's a general concern that nursing facilities and assisted livings are not until cycle 4 for their rebase.
If I can clarify one thing on that, Michelle, is that the nursing facility and assisted livings do get an update every year for other reasons that are not necessarily looking at the cost, whether it's because of provider tax or other things and the acuity adjustment. So I guess to be clear, there's not a suggestion to change what is happening already now with those service categories. It's more to look at the more explicit and in the weeds, look at the costs and the things that are not part of the regular cadence already. So I don't believe there's anything that is was suggested or recommended that DMMA in particular is doing right now that they would not continue to be doing at the cadence they're doing now, is to add on the additional layer as well.
And there's a general overall question about how the DHSS determine which updates or rebases are a part of which cycle.
So again, we tried to look at, as Mark said, like what is happening now, mostly under Medicaid, where there's continuous updates, as well as we know we have childcare. And the reason childcare is in cycle 1 is because this is the year that we just had to do the market rate study per the feds as part of our taking federal money and using federal money to fund the subsidized childcare program. And then the substance use disorder, again, we have a federal grant from Centers for Medicaid, Medicare and Medicaid Services. And then we looked at, what is next. So we already have, some conversations and some work happening in the behavioral health space. So it was trying to be realistic about the, 1, what is already happening, 2, what is either tangential or related to rate rebases that are already occurring, And then also just be cognizant of the staff time that all of these different things take, and realizing that rebases take time. And as Mark pointed out, and as others have raised in the questions, like we want to do it well. We don't want to do so many things at once that we're like, oh, I'm sorry, we didn't have a chance to update you because we were trying to do all of these rebases at the same time. We want this to be a robust process that has the level of engagement that people say, just like with the IDD provider rates, we know if we get another dollar, what we're going to do with it, because we've had the conversations, the methodology has been discussed. Again, it doesn't mean that the state is at 100% of benchmark, but the actual methodology, why we're doing what we're doing and what we're going to do with another dollar, has been something that has been vetted and worked through with the stakeholders. So that, again, DHSS can be transparent about if we get new funding, where does it go and how far are we away from the benchmark and what does the benchmark mean? We want to do that for all of these services and realize we can't do all of them in a single year. So we put that out, we put this timeline out there as an example. We didn't get strong feedback on it. We have presented it to JFC as our proposed path forward, and they just received this, and we haven't, as far as I'm aware, received feedback on changing this calendar or cadence. But again, if we get other feedback from CGO or JFC, we will consider that. But again, we think this is a realistic segmentation of the services, given the time and intensity a rebase takes for each service.
The final question that I have is, have you been able to establish a timeline for the start of each project? So if a project time frame is estimated at 12 to 15 months, is there a calendar yet for the start of each project?
Yes, there is. I mean, that's really, again, part of the next category of work, is to say, if this is the DHSS recommendation, if this is what we're doing, we can then say, okay, now we actually have to do the work, engage a consultant to actually now work through the rebases with us. And then we would be able to say for each service what the time frame is, and what the calendar and the level of stakeholder engagement, but we don't have that right now to give people, because again, this was our recommendation of how the rebase cycles would move forward.
I do not have any other questions in the chat or in the Q&A box.
I'll pause. See if anyone has anything else. Michelle or Deva or Sarah, was there anything else you all wanted to add? There's others from DHSS that are on. I'm just looking through the chat box. All right, I will add again, we appreciate and acknowledge that this is a lot of work, because we haven't been doing these for all of the categories. And so I do appreciate and acknowledge this hasn't moved forward as fast as people would hoped. And we also know that, again, my disclaimer with all of these is, even if we establish a benchmark rate and say we are at X percentage of benchmark, it doesn't automatically mean that the state or JFC or whomever is able to appropriate the money to get to a higher benchmark rate. But again, we thank the JFC and think this epilogue language, both the original and this updated, has been incredibly important in setting a direction and really a mandate for the state to be predictable, transparent around what our rates are and how did we arrive at that. And again, if we get another dollar. So again, I really appreciate everyone who's participated in this process to date. We greatly appreciate our provider partners that together serve very vulnerable Delawareans alongside our department. And we look forward to continuing to do this work with you. Thank you all so much. And if anyone has any additional questions, obviously this is not the last time we're going to be talking about this subject or rates or any of this. So please feel free to continue to reach out and submit questions or feedback for us as we move along. Thanks, everyone. Have a great afternoon or evening, whatever time it is. Thanks.